Right, we'll have a look at avian imaging. The first thing again, physical restraint. There are these things that are produced, these Perspex restraint boards. I mention them for completeness sake because you will see them if you buy some of the radiographic exotic pet imaging textbooks. I know they are much favoured in some parts of the world. Personally speaking, I'm not a fan of them. I don't think they're particularly humane. Most birds will freak, and if you've got a bird that's got something wrong with it in the first instance, I think it will be less than helpful to physically restrain it in what is effectively a stocks and then ties that can be then positioned to strap it down to a plate. So personally speaking, I would always anaesthetise a bird to radiograph it, unless again all you're doing is like a swan, you know, you want to know if there's lead shot inside its gizzard, so you just plonk the thing in a swan bag on the plate and take a shot, because all you're wanting to do is there lead in it or is there not? Okay, you're not too worried about positioning, and the swan's already somewhat restrained anyway. So I'm not a fan of these, I have to say. We mentioned obviously ISO and SIVO. Two views are recommended, clearly. Again, we can do skyline views. Ventrodorsal is typical. Right lateral, you may want to do a left lateral as well in some cases, because it can be useful. The difficulty is getting the legs out of the way so they're not obscuring the caudal coelomic cavity. You'll also note that in these instances, you're actually taking the same view of the wings in both images, okay? So you're taking effectively a ventrodorsal or dorsoventral view of the wings in both. If you want to get an anterior-posterior view of the wings, it's incredibly difficult to do without actually physically holding the bird, you know, pretty much upright or upside down across a plate and then firing a beam, which obviously for health and safety reasons, I can't recommend that you do. But there is pretty much no other way of being able to do it, to be brutally honest. To be fair, you can usually work out what's going on with the wing, it being fairly thin from one view, but it does make life a little bit more tricky. I just wanted to put this up to give you a bit of an idea as to the sort of variations that one can see, particularly in the skull of birds. There's a lot of variation throughout the whole body form in birds, but with the skull more than anything else, there is a lot of species variation. We have passerines, we have ratites, we have psittacines, we have more psittacines, sorry, we don't have psittacines, we have psittacines, we have vultures, we have duck. Waterfowl over here. So the typical sort of raptor, a vulturine type beak. We've got obviously a recurved bill. We can see there's a difference between the bone underlying the upper beak and the rhinotheca, the actual outer covering, the horn that's over the top of it. We can also see how large the orbit of the eye is, and we can also get an impression there of the scleral ossicles. These are just about visible around here on the eye here, much more difficult to see on the passerine because it's quite small. The duck, you can see it just in here. The Psittacine, we can just see it in here. So these scleral ossicles are around the scleral corneal junction. The avian eye is quite large, and in cross section the bit that actually sits in the globe is kind of this sort of shape, so the socket is like that, and effectively the scleral ossicles sit around this sort of junction here in a ring to support the front part of the eye. They're very faint, they are cartilaginous, and they're a series of plates to a ring, but they're a normal feature. We can see that the cervical vertebrae are fairly basic and box-like, but maybe slightly more elongated in the longer neck breeds, and there will be variable numbers. We can have, you know, significant increased numbers of cervical vertebrae in long-necked species. In the case of all species, they tend to have relatively small auditory bully, but some of them, particularly the birds of prey tend to have slightly larger auditory bully, so hearing is a better sense as far as they're concerned. In the case of the Psittaciformes, we have a kinetic hinge joint at the top of the beak and the upper bill, which is a synovial joint. So there's an elastic bit of pliable bone over the top here, and there is actually a little synovial joint at the junction between the upper bill and the skull, which allows the parrot to create the sort of crushing forces that we know. When you open the beak up, there is a series of complex bone movements that result in the upper beak also being elevated. So you pull the lower beak down, the upper beak also comes up, and this is associated with the movements around the temporomandibular joint with the quadrate bones, the jugal arch, which runs underneath here, and the palatine bones. And these bones are typically the ones that we want to look at in window strike cases where there are potentially skew-whiff beaks in parrots, because it's often these bones that become damaged when a bird flies into a car or flies into a window, and they break, and then when they fix really well, but often they fix on one side with an overriding bone and therefore shorter, and then the beak starts to deviate off to one side as effectively the whole upper bill has been pulled to one side. So we're looking in this area in here at these bones for evidence of foreshortening or evidence of callus formation. To be fair, in a lot of cases, we're not going to do any sort of surgical repair in this case, but there are obviously external beak adapters that I'm sure Neil will talk to you about that you can put on them to try and, a little bit like braces on teeth, that you can try and tension band these things back. In the case of a lot of waterfowl, you can see the serrations to the beak. They also have this thing called a nail at the end, which is a sensory plug right at the end of the beak, which is a little thickening, which is a normal feature. We can see the trachea in all of these cases, and just how wide the trachea is in comparison to the size of the bird. So actually, again, just demonstrating birds are relatively easy to intubate because they have a significant size or diameter trachea in relation to body size, unlike mammals. So a lot of species variation. Psittaciform body forms, just to give you an overview of relatively normal body forms. So we've got the ventrodorsal, the lateral, we've got a lateral limb. And starting from the top to the bottom, first thing to notice on the skeleton, we've got pneumonized humeri. In a lot of Psittacines, actually, the femurs are not pneumonized or are lightly pneumonized at the top end, but actually we still generally, as a rough rule of thumb, say don't use the femurs for intraosseous catheterization, because in the vast majority of birds they are pneumonized. It's also difficult to put a catheter in that area. We're generally looking to put it into the ulnar bone, which is the larger bone of the two in the distal wing. So avoid the humeri. Coming down to the shoulder joint, what we've got is two coracoid bones. So these are bones peculiar to birds and reptiles, and they act as a strut or buttress for the shoulder joint onto the keel. So we can see them in the lateral view here, down onto the keel itself. Fractures in this area are common again in birds that are involved in road traffic accidents or fly into windows. There's a lot of debate about whether you should or should not fix them. Some people feel that firmly you should fix them. I am generally of the opinion that you shouldn't bother. It takes quite a lot of effort to get down to them. You have to cut through the pectoral muscles. They generally heal just fine with cage rest, and most birds fly perfectly adequately afterwards, but that is a matter of personal opinion for some vets, some avian vets. So you will get varying views on that one. However, coracoid bones, stout, supporting the shoulder joint. The scapula actually is these little tiny spicules of bone here, which you can probably just see here and here. So it's a fairly insignificant bone, but also articulates at the shoulder joint. And then another bone articulates in that area, which is the furcula or the wishbone, which is just up the top here, which is fairly small in parrots. It can be quite stout in strong flying, long distance species, like a lot of duck and things like that. It can be quite a solid bone in that area, and that provides a bit of spring to the whole sort of pectoral area for the recoil of the muscles. The pectoral muscle mass, as you can see, lies in this area here, but we can also see that there are darker areas, radiolucent areas, inside the pectoral mass. Difficult to see on the lateral view, but more obvious on the ventrodorsal. These are outpouchings of air sacs and air canals connected to the airways. So this is between the deep and the superficial pectoral muscles. They're connected, as you can see, to the humerus. And so actually this area in here is effectively connected to the airways. The keel bone, if we want to get a rough idea as to positioning, we want to look at how square on it is. We want to try and get the keel bone overlying the backbone, so we've got it fairly square on. We've got the legs a little bit too far over, really. You really want the legs further back, so it's not a great positioning on the lateral view. If we come down, we've got ribs, obviously. We've got the heart shadow at the top here, and in Psittacines we get this typical hourglass shape. So heart shadow at the top, two liver shadows at the bottom. On the lateral view, this is the heart shadow here, and we can see the aortic outflow, we can see the pulmonary return, we can see the pulmonary outflow, and then the liver is actually pretty much obscured in this area, down in this area here. The true acid-secreting stomach, the proventriculus, sits slightly to the left side. It's in this area here, overlain by part of the liver. On the lateral view, it's in this area here. Then we've got the gizzard, or the ventriculus, the grinding stomach, which is well developed in Psittacines and Galliformes, poorly developed in carnivores. This one's got grit in it, so you can obviously very clearly see it sitting down in here. And then the intestinal mass is in this area here, in this area here, the cloaca and the vent out the back here. This dark area in here and these dark areas in here are the air sacs. So these are the very thin-walled receptacles that allow air to move backwards and forwards through the lung field. The lung field is actually in this area here, and is actually relatively difficult. It's a sort of a stippled effect, which is normal, and it's almost completely obscured by the pectoral muscles and the heart in the ventrodorsal view. So it's actually quite difficult to get an image of what's going on in the lungs in the majority of birds. These are the air sacs. There are paired air sacs. There's usually two two cervical air sacs at the top, then two cranial thoracic air sacs, two caudal thoracic air sacs, and two abdominal air sacs in the vast majority of Psittaciformes. And they each have, on each side, a stoma that connects with the relevant lung. So effectively they are outpouchings, balloons that come out from the lung. And as we mentioned before, typically the respiratory cycle is through the lungs into the caudal air sacs, from the caudal air sacs back through the lungs into the cranial air sacs, from the cranial air sacs back through the lungs and out of the bird. And so that actually an air molecule, technically speaking, goes through two cycles of inspiration and expiration before it exits the body of a bird. So it has maximum chance of extracting oxygen.
Does the appearance of the air sacs change with where it is in the respiratory cycle? Do they kind of inflate and deflate, or do they stay largely?
They do move, because it's obviously the main movement for inspiration and expiration is movement of the sternum down and out, and the rib cage out. So there will be a little bit of inflation and deflation of these air sacs, absolutely. So yes, again, ideally you want an inspiratory view if you can, because that's going to give you the greatest contrast in this area and give you more information. The kidneys are tucked up in this area here. So this area is obviously the pelvic area, and this is another area in birds where the anatomy is slightly skew-if. They've got fused sacral vertebra to the roof of the pelvis, and so actually the pelvis almost looks as if it's upside down in birds. They've got this shield over the top, instead of in mammals where you've got the wings of the ilia and then a pubis on the bottom. The pubis is unfused and are just two pubic bones, and obviously because birds lay eggs, you can't have a fused pubis, otherwise you'd never get an egg to pass through that area. So these two pubic bones are unfused and they just support the caudal body wall. The coccygeal vertebrae are relatively mobile, but at the end there is a fused lump of coccygeal vertebra, which is known as the pygostyle, and that is where the deck feathers, the tail feathers, are attached. So that they're actually physically attached to the periosteum of the fused last 2 or 3 coccygeal vertebra, which provides a platform for those flight feathers. Interestingly, we'll see on wing images later on, the secondaries are fused to the periosteum of the ulna, and the primaries are fused to the periosteum of the metacarpals and the carpal bones. There are no flight feathers attached to the humerus. Although it looks as if a bird's got feathers all the way down, next time you pull one out, have a look, there are no flight feathers in this area here. If we come back to the pelvic limb, we've obviously got 2 femurs, we've got a stifle joint with a patella. So there is a patella in there. There's sometimes in larger birds obvious sesamoids. We'll see in a minute there are often significant mineralized cartilages in the tibiotarsal area. This is the tibiotarsal bone, equivalent to the tibia in mammals, but it's called obviously a tibiotarsus because distally, technically speaking, the proximal row of tarsal bones is fused to the end of the tibia, and therefore the joint that we would associate with the hock is actually an intertarsal joint, or sometimes referred to as a suffrago joint, and the distal row of tarsal bones is then fused to the metacarpals. In parrots, you see it more clearly on this image here, so we've got femur, we've got tibiotarsus, intertarsal joint. This is the tarsometatarsus, so what was the fused distal row of tarsal bones onto the metatarsals, and then we've got the phalanges. And typically a parrot has this zygodactyl foot, so it has 2 digits pointing forward and 2 pointing back. Digit 1 points back, digit 2 and 3 point forward, digit 4 points back, digit 5 disappeared. And typically digit 1 has 2 phalanges, digit 2 is 3, digit 3 is 4, and digit 4 is 5 phalanges in a typical Psittaciforme. We do get obviously other foot forms, so we get the anisodactyl limb, which is typical with raptors and with passerines, where digit 1 points back and digits 2, 3 and 4 point forward, and then we get a few weird species like the osprey that has a semi-zygodactyl foot where it can flip digit 4 both forward and backward, mainly an adaptation for trying to catch the slippery fish. So it's got the ability to flip this backwards and forwards. As we said, kidneys down in this area in here, so they're difficult to see on this image. And otherwise, body form is relatively similar between different species of birds. But the other thing to note is that the vertebrae in the back here, in the thoracic area, are also technically fused. We'll see some better images than this because it's difficult to pick up on this one. We've got fused vertebrae here in the sacral area. We often have 1 mobile lumbar vertebra, and then we've got fused vertebra here in the thoracic area to provide a platform for flight. Cervical vertebrae are mobile, coccygeal vertebrae, apart from the last few, are mobile, but otherwise there's a lot of fused vertebra. The 1 mobile lumbar vertebra is an area to look at, again, for birds that have been involved in road traffic accidents or window strikes, because it's a weak point. It's one area that often becomes damaged. So that's a normal parrot. If we look at a normal owl, then we begin to see a few obvious differences. So first of all, we don't have that hourglass shape. So that's something that's relatively peculiar to Psittaciformes, that hourglass shape. It's really useful when we're assessing Psittaciformes, as we'll see in a minute. But actually, in other species, it's often more a tubular form. Again, the heart's at the top. We've got liver in here, and then we've got quite a distended abdomen in here. This one's had a meal fairly recently. We've got the proventriculus coming down into the ventriculus in raptors. There is not really a differentiation to look at. There's not a grinding gizzard because they're obviously digesting meat. What they've got is an acid-secreting top part to an enlarged stomach, and the bottom bit is kind of just a sac that sits there and holds the food while it's being digested before then going out into the intestines. Lungs, again, up in this area here. We can see perhaps slightly more easily the 1 mobile vertebra in this area here, synsacrum, the fused sacral vertebra with the roof of the pelvis over here. The other thing we can see, this being an owl, slightly weirdly, we've got the fibula just here, but we're also starting to get, you can just see the image of these fine striations. Owls often do have quite mineralized cartilages, ligaments I should say, in the muscles in the tibio-tarsal area. Again, they're quite good with the feet, owls, and this is thought to be to strengthen the muscle function. We see this really significantly mineralized in long-legged birds and galliformes, which we'll see in a minute. Otherwise, body form relatively similar, slightly less pectoral muscles. We can see the pneumonized femurs in this particular one here, the obvious gas pockets in the medulla, and we can also see a little diverticulum of the caudal thoracic air sac coming down here in between liver and stomach in this particular species, which is just a feature of this particular individual. If we come to Falconiformes, falcons, again, more of a tubular sort of visceral body organ system with the heart at the top, the liver shadows, again proventriculus in this area here, air sacs around here, pneumonized femurs, lateral view, heart here, proventriculus coming down here, bit of liver shadow in here, intestinal mass, kidneys, air sac, lungs here. And again, foot-wise, they have this anisodactyl limb, and there is often additional sesamoids in these birds in the regions of the intertarsal joint. So there's often additional bones. You'll find these occasional sesamoids. You may also find them in the carpal areas, which are all about providing a smooth running for large tendons. So remember, obviously, raptors use their feet predominantly. That's their main killing weapon for the majority of them. So they have strong ligaments, strong muscles associated with the foot, and they often have these sesamoids to encourage smooth running of these large ligaments. For ducks, for waterfowl, physiologically, this has a large egg in it, which is waiting to come out. We can see a few peculiar things. We've got a flattened keel, so obviously ducks swim, so they tend to have not a very prominent keel. They're good strong flyers, but it tends to be flattened. They have a very strong looking clavicle and quite significant again coracoid bones for good strong flying, pneumonized femurs again, quite a large heart in comparison to body form, and in this particular case, as I say, obscured by eggs and things. So we've got a little bit of a grinding gizzard down the bottom here, so they're sort of a little bit more like Psittaciformes and Galliformes, but they do have a proventriculus and a gizzard, but otherwise the body form broadly similar. We sometimes also see, and it's worth just noting, where the trachea comes into this area here, in males, you may get a significant diverticulum around this area, which is often referred to as an auditory bulla, and that's actually relatively normal. It appears as a gas-filled chamber in this area where the syrinx should be. So remember, birds, the voice comes from the bottom of the trachea, not the top. And a lot of ducks, you know, that long annoying call that can keep you awake all night, will have in drakes a resonating chamber on the side of that, which appears as a large mineralized structure just to the side of the syrinx. And then Galliformes. So when we get to Galliformes, again, grinding stomach like the Psittaciformes, quite a lot of digestive tract in Galliformes, so it tends to fill a lot of that caudal coelomic cavity. We've got a significant area in the front here for a crop. So not all birds have a crop, so a lot of the Psittaciformes, Passerines, Galliformes have one. Galliformes obviously have a particularly large crop, so we've actually got a recurved a keel, a shorter keel bone in this particular case. They have a sort of an intermediate hour-shaped figure, not particularly wasted in the middle there, as it is with Psittacines, quite stout limbs, because obviously these guys spend a lot of time on the ground, and they've got lots of mineralized tendons in the muscles, ligaments in the muscles. Tendons, I should say. And then small passerines, So again, a body form similar. We've got again heart at the front here. We've got a grinding stomach depending on the species. This is a little thrush that's actually got some mineralized deposits in it. It's picked up some metalwork. But longer limbs. So we've got longer tarsometatarsal areas. Remember in the Psittacine, this area is really short. These guys much longer legged in that area. But we can also get the impression of these flight feathers attached actually directly onto the periosteum of the ulna in this area. So when you're pulling flight feathers, again, I'd encourage you to anaesthetize birds before you start pulling out flight feathers. It is painful. And there is a small risk that you can create a little bit of a periosteal reaction, which can then encourage them to have a bit of a feather pluck at the area because it's sore afterwards. We can do contrast studies in birds. They are somewhat difficult because you need to effectively try and do it conscious and then anaesthetize the bird and do it conscious and anaesthetize the bird. They have very short gut transit times. In most cases with Psittaciformes, you're talking from one end to the other in a matter of 2 to 4 hours. So this is really quite normal, but we can see into the crop in this area here, into the proventriculus, into the ventriculus, and we're starting to get into the intestines. So we can see the course of the proventriculus left side into the ventriculus and then into intestinal mass. Crop, most species tends to sit predominantly to the right side of the neck, but a lot of them it's quite large and actually comes across both sides of the neck. Why do we want to do contrast studies? Well, we could look for foreign bodies, and you can see, sorry, we'll just flip back to this one. We can see the infilling with food ingesta in this area here, and so that may be useful. However, we may also, particularly in parrots, want to look at conditions like dilatation of the stomach. So this is proventricular dilatation disease, which we know is associated with a Bornavirus infection. So we've got two grey parrots here. This is a normal barium contrast in this particular one. This is abnormal. What we've done here is we've actually under anaesthesia, which is a technique which makes life slightly easier, instead of just crop tubing it, under anaesthesia, if you're careful, you can actually, with a straight crop tube, gently thread, or indeed with a feeding tube, work your way down into the crop, which you can palpate down the neck, and then work your way into the cranial chest. So actually bypass the crop, go over the top of it, and then just inject your contrast in that area. It just means that you can then immediately take your x-ray and know that it's actually going to go into your stomachs. And this one here, we can see we've actually got distension of the proventriculus, widening of the proventricular-ventricular junction. This one's a more normal one with a contraction wave, and this is typical in early stages of proventricular dilatation disease. Diagnosis of proventricular dilatation disease is still usually made based on either PCR detection of the organism, serology, or biopsy either of proventriculus, or more typically, because it's less risky, biopsy of the crop. And usually you biopsy the crop over a blood vessel, so you get a nerve with it because you want to look at the nerves for evidence of lymphocytic, plasmacytic infiltrates, which are typical with proventricular dilatation disease. But confirmation with radiography can be useful. We can obviously see issues with metabolic bone disease. We mentioned a little bit about this yesterday. And we typically see this obviously in young birds, captive ones. These are a Psittacine chick here, where we've got folding fractures of the tibiotarsus here. We've got folding fractures of the humerus. We've got obviously very abnormally shaped tibiotarsal bones here with a 90-degree bend in it. These sorts of injuries, spontaneous folding fractures and the like, are not reversible. These are not manageable. So this particular individual unfortunately was euthanized. But we can see it in wild birds as well. So it's not just a disease of captivity. This is obviously a husbandry issue. So this is a wild bird. a raptor, and we've got tibiotarsal bowing, and it's usually the tibia tarsi or the tarsometatarsal, the long bones of the legs, which are the ones, and it's often, you know, in things like barn owls with the lesser chicks. Obviously they have a hatching regime with barn owls, and the later chicks often are not being fed as well and being outcompeted, and if they survive, they often have mild metabolic bone disease issues. They've grown, they've got quite heavy, but the weight on the bones then causes them to bend. So it's not unusual to find these skeletal deformities in wild birds as well as captive ones. We talked about looking for injuries, and this is this mobile lumbar vertebra, and this is quite a good place to look when you've got birds that have had window strike or car strike injuries and you're concerned about pelvic limb function. They maybe aren't gripping well, or they're maybe not even standing at all, but seem very bright at the front end. This is the area to have a look at in the first instance. So we've got cranial end, obviously this end, the two humeri. This is the notarium, the fused thoracic vertebra. This is the synsacrum, the pelvis and fused sacral vertebra. And this is your mobile single lumbar vertebra at this point, and this is your weak point. It's there because obviously it allows swivel movement of the caudal end of the bird, so when it's flying it can maneuver itself with its tail feathers to actually steer itself. So it's there for good anatomical reasons, but of course it is the weak point when a bird hits something and the back end then follows in to the front end. That's the area that often subluxates, disc collapse or fracture. So it's worth taking a couple of views of that. We've got a compression fracture here and a partial subluxation. Yes, these are grim prognoses. Other things that are common in birds and that we really need to look at quite closely are the feet of birds, particularly in raptors, but also in perching birds and waterfowl, because bumblefoot pododermatitis is really common. And with pododermatitis, I'd always encourage you to, even if you think it's superficial and soft tissue, I would encourage you to do radiographs of the feet, because ultimately, if there is periosteal reaction of a mild level, the prognosis is that much worse. And so you're keeping your client well informed as to the prognosis, and you'll find with some raptor owners, that the cost of treatment is going to far exceed the value in their eyes of the bird. Similarly, you may have an owner that wants to spend whatever on it, but it's still important up front to have a better idea of what's going on. So we may have feet where we've got serious periosteal reaction and bone formation, bridging joints. We may have soft tissue reaction, so we've got a normal foot here, we've got soft tissue reaction associated with a central pad here. We don't appear to have bony change. What we do have is a little bit of soft tissue reaction going around the nail bed of that particular foot. We may, however, have complete joint abscessation and disruption, as we've got in this duck down here, or we may have just fluffy periosteal reaction and loss of contrast and detail going on. Anything with bony involvement, anything with joint involvement clearly carries a worse prognosis. If it's just soft tissue and it's not affecting tendons, the prognosis is good. If it's affecting tendons, the prognosis is slightly guarded. If it's into bone, prognosis is usually poor. It doesn't mean to say that treatment can't be tried, but it's going to be expensive, it's going to take time, and it may fail.
Do you see mineralisation of the tendons?
In long-standing cases, yes, that is perfectly possible to see mineralisation of tendons. Yeah, absolutely. Usually, owners have brought cases to us before then, but yeah, I mean, if they've been left, absolutely. And again, we may be able to determine other things. This is a cock of the rock. It's an Andean species. These things exchange hands for about, this is the male, for about £40,000 a pair. And unfortunately, there's therefore a regular trade in catching them in the wild and bringing them into captivity. And we see a lot of this, unfortunately, in birds. We see an awful lot of it in reptiles, although they're rarely quite as valuable as the birds. And typical open rings. We've got, in this case, evidence of an old healed fracture on the leg. They're often fairly simple, low technology, feed the bird on the ground with a trap net with a stick in it that you pull out the way, and then the trap door comes down and whacks the bird, and they catch it. But we can also see other evidence You know, historically, this is a wild osprey that has been shot. It has broken the radius. The good news is radial fractures usually heal quite well on their own. The bad news is if it's a falcon, then that can be a real issue because you often get a synostosis forming between the radius and the ulna, and most of the falcons need, you know, really fine flight, and particularly anything that hovers. Ospreys may be also affected by that, perhaps slightly less. If you're talking about things like buzzards and things like that, they usually do really well because they're big soaring birds and they don't need that fine wing control. So again, when we're talking about prognosis and radiographic signs, depends upon the species you're dealing with, depends upon what the owner's using that particular individual for, if it's owner related. If we're releasing it back into the wild, then okay, we need to think carefully about whether or not this particular species individual has normal wing function. Can it function in the wild, or am I putting back a bird that is just going to starve slowly should that happen? But yes, forensic stuff, sometimes you find stuff that you kind of go, oh no, really, open ring and a fracture that's healed does make you feel a little bit nervous. This is just some images of the wing, just to give you an idea about how well seated those flight feathers genuinely are on the periosteum. So they're right onto the bone, the ulnar bone here, and onto the carpal bones, the metacarpal bones, sorry, and phalangeal bones. Primaries on the hand of the bird, secondaries on the antebrachium, nothing flight feather wise on the humerus. Propatagium along here, and we can just see obviously the little increased spots on it, which where flight feathers are attached. We've got the little thumb of the bird, so they've pretty much got a major digit and a minor digit to the distal wing, but they've also still got a thumb, the alula, sometimes referred to as the bastard wing, but it's there for controlling the airflow over the surface of the wing. It's very well developed in birds that hover and glide, and they'll use it. It's got a tuft of feathers on it. Some species of birds, they actually still have the prehistoric claw on the end of it. So do any of you have chickens? Old breed chickens? Things like light Sussex or Marans or things like that. Have a look closely the next time you get to your light Sussex or thing at the little tufty thumb, the alula. You'll find a claw. It's still there in the chickens. It's there in peregrine falcons and things like that as well. So a lot of birds still have that prehistoric Archaeopteryx claw in that area. But it's there effectively a bit like an aileron in a plane, and it's on the leading edge of the wing to control the speed of airflow over the wing, so that stops them stalling. They can flip the area up and down. So actually that's quite important in some species of gliding birds. If that's broken, that's not necessarily good news. This is the anterior-posterior view of the wing, which you absolutely can't do with holding a bird, but sometimes you can get a bit of an idea. The wing's not straight. You often think the wing's straight. It's not straight. It has to have a bend on it. So the whole wing is actually bent to form that domed, what we associate as a wing shape, to give that lift. So this is the underside, the ventral aspect, the dorsal aspect. You can see the flight feathers curling in there. Humerus, elbow joint, ulnar, radius, carpal bones, metacarpals, alula in there. Why is that area quite important? Well, not just to see that, because also we can get, this one's a bit dark unfortunately, but you can get an increased idea. We've got increased radiodensities coming all the way down here. This is oedema, this is wingtip oedema, which is typically associated in birds of prey with frostbite. It can occur through thromboembolic disease, but it's much more commonly associated with frostbite. So tethered raptors that are tethered outside or tethered in weatherings, these three-sided, often roofed enclosures, which are typical for housing during the summer, and then you get an early frost, and the bird's tethered low to ground, and they get frostbite in the wingtips. And so blood supply is compromised, you get edema, as you'd expect with any sort of necrosis. And unfortunately, in severe cases, you'll get wingtip sloughing associated with it. But you'll get this typical pattern of increased radiodensities around the feather shafts coming into the wing. I mean, you'll be able to grossly see that obviously the wingtip itself is discoloured. But this, when you've got radiographic changes as well, the prognosis is therefore not so good. Obviously, birds particularly lend themselves to external fixators, fracture repair and so on. So radiography is key to ensure you've got good positioning of fixators. So we're starting to assemble this particular one here, and avoidance of joints, and make sure that you're actually engaging both articular surfaces. They may be simple like that one, they may be quite complicated and long like this one, with long-legged birds. So this is the tibia tarsus of a flamingo that we've got multiple pins attached to the outside of in an attempt to bridge and support that. Fractures often in raptors, actually this is a Galliforme, but often in raptors will occur in this tarsometatarsal area, which is where the jesses are going to be, because that's often a common falconer's novice mistake, is to tether a bird on a leash and leave the leash too long. You want it long enough that the bird drops off its perch, that it can get to the ground, to its water bowl or whatever, but you don't want it so long that the bird can, if it's frightened, can get up to speed, because then when the leash snaps taut, that's going to put extreme pressure on the jesses, which are attached to the little anklets which are around this area here, and then you get fractures. This particular Galliforme had a big solid ring on it, which it managed to catch on something and then panicked and flapped and broke its leg. So this is a pheasant that managed to do this, and then these are difficult to get things across. So we've got an external fixator made of ECF putty and multiple transarticular, transcortical and single cortical pins to go through it, but these are messy fractures, and in a falcon these are going to be difficult to avoid tying down tendons. That's the big problem with surgery of that. Neil will definitely talk to you more about that sort of thing. The chances of the bird being having effective use of its foot afterwards in a falcon is guarded. Beak fractures are another common problem, and we see this obviously particularly in some of the longer beaked birds. So this is a stork, the black stork that we've got here. We've put a little external ESF putty fixator on it. These guys, it's really more to highlight the fact that when you fracture a beak, it is difficult to put external fixators in it, and for the external fixators to be sited in bone that is sufficiently dense that it's going to hold. In some cases, if it's loosely aligned and it's being held somewhat by the actual horn, by the keratin, the natatheca in this case, that's covering the beak, actually using a kind of an ESF putty type technique, or gluing straps across it to buttress and support it from the outside, is preferable to trying to stick pins through it, because the pins loosen with time, and they're not embedded in anything solid, as we can see in here. When you get to smaller birds with fractures, these ones can be particularly difficult to manage. This one's actually got quite a nasty disrupted intertarsal joint and knee joint as well, so this one's probably not long for this world. We see a lot of cardiac cases in parrots, and so this is a galah cockatoo. And just to orientate yourself again, ventrodorsal view, got it relatively square on. We've got the keel overlying backbone, coracoids, humeri, femurs, heart shadow, liver, proventriculus, digestive tract, air sacs, lungs. So subjectively, we've got a bit of an idea that we've actually got maybe less of a waist to that. On the lateral view, actually, it does seem that the heart rises quite significantly into the body of the bird. There are some rough rules of thumb that one can do in parrots in particular to assess cardiac size. And the first one of which is to look at the heart on the ventrodorsal view and measure the heart at its widest width, and then measure the chest at the level of the fifth pair of ribs, which is usually the widest point of the cranial part of the coelomic cavity. And you would expect that the heart width should be less than 50% of the width of the widest portion of the chest. This is relatively subjective. It works relatively well in parrots. It does not work terribly well in a lot of other species. And unfortunately, again, rather frustratingly, that is kind of where we're stuck at this precise moment in time, because actually, cardiac heart scores have not been worked out for the 99.9% of species of birds. There is a paper in the most recent Journal of Avian Medicine and Surgery, for all of you enthusiastic avian vets, on the radiographic reference values for the cardiac silhouette in Bonelli's eagle, which is great if you've got a Bonelli's eagle. And they are looking at comparing the cardiac silhouette width should occupy 81 to 93% of the sternal width. So they're measuring the silhouette versus the sternal width. It should be 48 to 50% of the thoracic width, this bit, and it should be 506 to 673% of the coracoid width. So they're actually going in for taking a whole bunch of measurements to try and find some reference value. And this is our problem, is that we don't have a lot of data on this. There's very little published. For psittacines, the rough rule of thumb, 50% at the widest point, is not a bad starting point, but it's about as good as we've got at the minute. I'm sure further papers, and I'm sure all of you will be writing papers as you go through your career on these things. So there's lots and lots of research you can get published. I mean, seriously, from practice, you know, you've got a breeder of African grey parrots and you want to produce a cardiac score, you probably can do it if you can get together enough radiographs. We may well see advanced heart failure, as we've got in this minor bird here, where we've got significant cardiac enlargement, and actually we've got ascites. We've got a complete whiteout going on in here, and this loss of detail that we've got going on in the coelomic cavity. And you can almost see, can you see this line that's appeared here, which is perhaps the most obvious thing on it? That is where the lungs start. I can't see any air sacs. Now, the air sacs are probably somewhat squished. They've not disappeared, but I'm now looking through air sac, through fluid, through air sac. Whereas normally I would be looking in this area through air sac, and body wall on either side, and that's it. And therefore it would be radiolucent. I've now got fluid in there. This is ascites associated in this particular instance with cardiac failure in this particular individual. Typically in parrots, one of the conditions we're most concerned about is aspergillosis. And in parrots, the good news is that aspergillosis frequently occupies the caudal air sacs. In penguins, unfortunately, it doesn't. It tends to occupy the cranial air sacs and the lungs, which makes it very difficult to diagnose. So coming back to the silhouette again, we've got the heart silhouette here. We've got the liver silhouette in here with a proventriculus. On the lateral view, we can see in this what should be a dark radiolucent area, we've got some infilling going on in here. It's not really clear what it is. On this view, however, we can see this particular lesion in here. And we've also got a little bit of an impression that although that's square on, it is nicely positioned, it appears that the viscera on this left side appears to be slightly closer to the left wall than it should be. Okay, we've not got a symmetrical hourglass like we should have in this area. And this is associated with adhesions and air sac scarring in that area, and that is a granuloma, an aspergilloma that's growing in that caudal thoracic air sac, which is typical of aspergillosis. We may see other symptoms which are much more severe with aspergillosis, and this African grey parrot here has lost completely the right side of its air sacs. So we've got cranial, caudal thoracic and abdominal affected, and the entire shadow has moved to the left-hand side. Again, we've got a nice square-on view. We've also got increased density in this area here, which is highly suspicious that we've probably got something down that side, but we can often get this unilateral one-sided image with aspergillosis. We can get other infections of air sacs which are not necessarily aspergillus associated, and we may actually see the air sacs. So this is a macaw. Macaws often have a very pronounced waist. They often have a very narrow looking hourglass shape and are quite a small heart size. They're often referred to as microcardiac on these images. And what we've got here is we can suddenly see a line, a radio dense area in between or in the middle of these air sacs on this image. And this is not a discrete granuloma. It could be aspergillosis, but it could also just be a general air saculitis. This particular one had psittacosis and had an air saculitis associated with it, because we shouldn't be able to see the air sac line. You know, these are onion skin thin. They should really be beyond the resolution range of most radiographic units. So if we're starting to see them very obviously like that, we've got thickening going on. We may also see ruptured air sacs. This one here is a bird that's had a traumatic incident, and we've actually got the cervical air sac has actually ruptured into the subcutaneous space and is starting to balloon out around the rest of the bird. So we can actually see it connecting in here, but it's starting to spread subcutaneously. And sometimes these birds, you pick them up and they're like bubble wrap. You know, they've got all this air underneath the skin because they've had a collision with something. One of them has ruptured into the subcutaneous space. And again, a serious aspergillus case in this grey here as well. So lateral view, you get a bit of an idea of an infilling going on here. Ventrodorsal view, yeah, okay, we've got something really serious going on here. We've lost the hourglass completely. The entire side is affected. That's going to be a grim prognosis, that particular individual. We may also see enlarged, other enlarged body organs, such as spleens. So, in this particular instance, we've got a couple of images. We've got a normal one here with nothing much going on. In this particular one here, you can see there's an image in this area here of a circular organ. It's difficult to see on this particular one, but it's in this area in here. But on the lateral, it's usually just above the gizzard and about mid-thigh, which is useful because if you can see it, the spleen of Psittaciformes is circular, spherical I should say, and it appears at about mid-thigh level, and if it's generally considered more than the width of the thigh bone, it's considered enlarged. So you sometimes occasionally will pick it up, but if it's very, very obvious, then it probably is increased in size, and then measure it against the thigh bone, and if it's more than the width of the thigh bone, then you've got splenomegaly. There are obviously many things that could cause splenomegaly in birds, but in Psittaciformes, one of the most common is psittacosis again. So it's another thing that gives you a little bit of information to make you concerned about a specific condition. We can see other things which are much more difficult to pick up on radiography. This one has got actually an enlarged kidney tumour. Again, we've lost the dark radiolucent area in these caudal thoracic air sacs. We can't see very much at all on the ventrodorsal image, but this is a budgerigar. These typically are associated with gonad or kidney neoplasia, and often infilling in this area, typically associated with unilateral limb paresis or lameness. In this particular individual, we've also got hyperostosis. This is a female. We've got hyperostosis of the thigh bone and the tibia tarsus, and this is typical in egg-laying female birds. The thigh bones and the tibia are often used as calcium deposition and mobilization sites, and these compulsive egg-laying female budgerigars often will have this increased radiodensity and slightly mottled appearance to these long bones. We can clearly see this particular, we can't clearly see on this particular image because the image has come out slightly wonky. This particular one we're supposed to be showing you. We've got an obvious fracture up the top here, a radius and ulnar fracture from a bullet fragment, and this particular one had GI stasis. I don't quite know what's happened to that particular image. I apologise for that one. We'll move on to another one. Yeah, this one's slightly better. Hepatomegaly, this is a badly positioned x-ray, so I apologise for this. Legs should be pulled caudally, they're up around its ears somewhere, and on this particular one here. However, we get a bit of an idea that there is no waist to this hourglass figure on this particular one. It was the most extreme one I could find, so it was worth pulling out. We've got something that's filling in the bottom end of the hourglass shape. Now, it could be that is a space-occupying lesion in the centre of the body, so there aren't too many things that are going to do that. One of the things, though, that could do it on the left side would be the proventriculus. So there's always a possibility you could have proventricular dilatation going on here, and it's pushing the lobes of the liver out. So that is a possibility. And therefore, we might want to do a contrast GI tract study in order to highlight where the proventriculus is to rule that one out. This happens to be an Amazon parrot, and it was a bit on the fat side, and certainly this is hepatic lipidosis in this particular case. if we've ruled out the proventriculus, we can then look at the liver shadow in these guys, and we can draw a line from the shoulder joint to the hip joint, and the liver shadow should fall between those two lines, okay, in Psittaciformes. If it is out with those two lines, either the liver is enlarged or there is something in between the liver, like the proventriculus, that is pushing the liver out and needs investigation. So a line between shoulder joint and hip joint, both sides, liver shadow should be within that line. And on the lateral view here, again, bad positioning, got the heart in here, we've got something filling that area in there. And actually it's all one organ. And you can sort of see the line that comes up the back here and across here and then down here and around there. And that's one lobe of the liver superimposed on the other lobe of the liver. The intestines are over here. This is a massive hepatic lipidosis. Clearly, birds are ideal candidates for diagnosing things like egg binding. This is a grey with a significant egg in it. This is why egg binding is an emergency, why we need to get this out of there, or at least relieve the pressure. You can see it's pushed a lot of the viscera back into the air sac area. This bird's often dyspneic, but actually it's putting pressure on the kidneys, which are up in here. It's putting pressure on the root of the mesentery, and therefore we can get ischemic necrosis. We can get other serious issues associated with that if that egg's not removed. And this particular image is relatively poor because we're dealing with a very poorly mineralized, very small little parakeet here. But this one has a collapsed egg. You can probably just get an idea, an impression of a collapsed egg in here. But we've also got a ventral hernia. That is its gizzard, that little bit of grit that's up there, okay? So we've got a massive ventral hernia, and this is typical with chronic egg-laying small parakeets. They often, with hyperestrogenism, they often have quite well mineralized thigh bones and tibia. So we've got this mottled appearance again. They often develop hernias, so the estrogen has a weakening effect on the muscle and the continuous egg-laying. And eventually they get exhaustion and they produce malformed eggs. Some of them get egg yolk coelomitis, a lot of them get egg binding and collapsed eggs inside it, and the egg can't negotiate its way out of the tract because the tract is now part of this hernia. So these guys have some real problems when it comes to the end stage of compulsive egg laying. Typically this is an egg yolk coelomitis associated with it. So again, gizzard is over here. We've got a ventral hernia in here. It was possibly a little bit of egg fragment just down here. But this one actually had an egg yolk coelomitis. So again, we've got a line appearing up here where the caudal edge of the lung field is. We've got general loss of detail in the coelomic cavity associated, in this case, not with ascites, but with coelomitis. So we've just lost all serosal detail in this area. We can obviously see the hernia. So that could be something like an ascitic bird, or it could be certainly egg yolk coelomitis, which it was in that case. Foreign bodies, easy to see. Penguins always swallowing stones and other things of that nature. Most of them vomit them back up again. Occasionally we have issues with them. But actually a lot of Psittaciformes in houses are inquisitive. These are little bits of pewter lead fragments that this cockatiel has managed to chew from an expensive wine bottle top and managed to give itself lead poisoning in the process. The good news is they show up really nicely, clearly on radiograph. The bad news is you've got to get all those things back out again. This is a Harris hawk. This one has, well, spot the very obvious thing that it's got in it. It's got an air sac tube in it. Okay, so we've bunged an air sac tube in it. So it's just gone through the body wall there into the abdominal air sac. So we're breathing for it because the bird wasn't breathing terribly well through the other orifice. What could you see that is perhaps not entirely right about this bird? Something above his heart, yes. What's that? It's a bone, yes. This bird was being flown for quarry and had managed to wolf down part of a rabbit before the owner managed to get it off said rabbit, had managed to wolf down 1.5 vertebra from the rabbit and then get it wedged in its, just in front of the proventriculus, right above the heart base, which was giving it some quite serious problems at this particular stage. Certainly breathing problems, because it was pressing on the syrinx and making it difficult to breathe and poking up into the lungs. And it was also causing a bit of a cardiac output failure. So occasionally you get weird things like that. Difficult to see on this view. So again, the advantage of 2 views. Yes, anaesthetised and then endoscopy. Yeah, you just needed to knock it back in and then pull it back out again. But it got it wedged across. So I don't quite know how it managed to do it, but it managed to get itself wedged. And then you get weird ones which sort of have been sitting around for some considerable period of time. So this is a crane from a zoological collection. We've got a microchip down here, up here. So long-legged bird, long-winged bird. They do have a little bit of an hourglass shape, but again, different body form. And we've got this thing up here, which is a nail. These are inquisitive birds. Cranes often have very stout furcula. They often have, some of them have coils of trachea in this cranial area, which give them some of the booming calls. But this one had managed to swallow a nail, and it had then perforated its gut, and had obviously been there for some time. But they're incredibly inquisitive and will pick up any sort of object that is in their environment. This is, or should be, in your notes. It is worth noting that we can increase magnification at the risk of sacrificing clarity, obviously, to a certain extent, but with small stuff, and this applies obviously to the small mammals as well, by increasing patient object to film distance in relation to focal to film distance. So basically we can raise effectively the patient above the X-ray plate or the imaging device, which will then create obviously an exaggerated image. So if we had our mouse on the plate, we're going to get our image like that. If we raise said mouse up to this level, bearing in mind we're doing it from a focal source, then what we're going to get is a super mouse on our plate. So the bad news is you will sacrifice some clarity in the process, but there is a rough rule of thumb for birds that's been worked out, which is as follows. So average weights of different species of birds, looking at different areas, KVs, MA, seconds, patient object to film distance and focal to film distance, to give that extra bit of magnification. So for ultrasound, birds do not lend themselves well to ultrasound because of the air sac system. So there are some exceptions to the rule in certain medical conditions, and we can use certain organs of the bird as acoustic windows. The liver is the most typical because it's close to the body surface, and we can use it to image things like heart and obviously look at the liver. But actually with a lot of the air sacs inside birds, it makes life very difficult. Psittacines also have a keel bone that comes right the way down quite far caudally, and then the pelvis, and they've really got a very narrow window that you can actually stick an ultrasound probe on. Things like Galliformes and Columbiformes have a deep V notch in the lateral body wall above the keel where the ribs come in a V shape, and you can often get the probe up onto the side of the body to image the liver and occasionally intestines. But that's not possible in parrots. Preferably this should be done under general anaesthetic so you don't get bitten and the bird doesn't cause it too much stress. We're generally requiring from most of the species we're dealing with 10 megahertz, if possible, transducers. And this is typical of what we can see using the liver as an acoustic window. This is that galah cockatoo, remember, that had the enlarged heart. So we're coming in from the caudal keel here, we're imaging through the liver and up to the heart. So the base of the heart's up here, the apex is here, this is the liver. We've got obviously a little bit of flashback here coming because we've hit part of an air sac on this side, and this is what makes life difficult. But we can see we have got a pericardial effusion we've got left ventricle, right atria, and we may be able to assess things like valves in these images, but we've got a bit of an idea that things are going wrong. We may be able to put across the valves, however, so we've got the faint outline of the heart here, and we're actually across the mitral valve here, and we may be able to assess valve function, and we may be able to assess turbulence in bird hearts, and we may, I'm hoping this is going to work, he said. Go on, work. This is the joins. It's not going to do it, is it? No. Okay. I'll try and see what I can do about that and get it up on your Moodle platform anyway. This is the joys of, I had to send these things through on Friday, and clearly it's not, it's embedded, but it's not linked. So this is the heart of a rainbow lorikeet, using the window as using the liver as a window, acoustic window, and we're coming in again through the apex of the heart to the base, and we've got the heart valves in here, and if this thing will play, then you'll be able to see the actual movement of the heart, but it's not a great image. This is a small 130 gram bird with a 10 megahertz transducer. It is difficult to get decent images in these small creatures. So we are getting a subjective image. This one, the heart was actually normal. We've not got any pericardial effusion. It seems to be functioning okay. The valves seem to be okay, but these are difficult. They're right at the kind of edge of the ultrasound capabilities. We may see obvious things. This is plugged onto the mid coelom of a parrot, and this is an inspissated yolk floating freely within the coelomic cavity. So you can get a little bit of an idea of the echo-dense yolk in the centre. We've got the slightly hypoechoic albumin around it. We've got a little bit of a shell, but we're getting into it. We've got more membranes more than anything else, but it's actually floating free within the coelomic cavity. It's not actually inside the salpinx in this particular case. So this is an ectopic egg production. We may get conditions like ascites, which make life an awful lot easier when you're trying to image, because then you can see these are layers of intestines here with a lot of ascitic fluid, a little bit of liver over the side here. This is an toucan that's got hemochromatosis, and ascites is associated with it. We may see hepatic lipidosis, as we've got in this Amazon parrot, where you can see the caudal vena cava coming back over this way. We've got generally an enlarged size of the liver. We've got increased echogenicity in comparison to this one over here, for example. And this is typical with hepatic lipidosis. And again, we can see other conditions. This is hemochromatosis, and this particular one here, we've got cavitating lesions in the liver itself. So we've actually got areas of hemorrhage and then ascites associated with this particular organ. So some things work and some things unfortunately don't in birds. CT works quite nicely for skeleton. This is a rockhopper. Just again to give us an idea of anatomy, so CT scanning, if your clients are interested in it for fractures, obviously in the first instance, most useful, but can also be used to diagnose things like aspergillosis. And of course, endoscopy is something that we routinely use in birds because they lend themselves so well to it. And for those who are not doing it, this is a typical left side of the approach. You can go in either left or right. Left is typically used obviously for sexing birds, or used to be, because the females obviously only have a left ovary. Birds placed in lateral recumbency under general anaesthesia, wings are held dorsally, legs pulled caudally. We're using the cranial edge of the thigh, so we're going in the same place we're sticking an air sac tube in. So basically halfway between backbone and keel, just in front of the leading edge of the thigh, making a nick in the skin, blunt dissecting with hemostats, and then popping a rigid scope in to have a look what's going on inside. And we can see varying different things associated with that, and this is typical with aspergillosis. So we can actually see the fungus growing in there, lovely fluffy horrible bread molds growing inside it. This one actually is not going into a body cavity, this is actually looking down the trachea, and this is capillaria in the trachea of a raptor. So this is a bunch of nematodes that are actually coiled up in the lining of the trachea. This is typical aspergillosis lung from a Gen 2 penguin associated with infections like this. So these are often really advanced and severe diseases. Right, what we'll do is we'll do a little bit of this, and we'll probably break early for lunch because I think Stephanie was saying that Georgia was here and wanted to see you from sort of 1:30ish. So what we'll do is we'll do another 10-15 minutes. In fact, actually, just excuse me just 2 seconds. I'll just check whether lunch will actually be ready at 12:30 because that will be useful in the first instance. There's probably still going down there sitting glumly while I'm having served it up. I'm just going to check on that and see if we can just break early for lunch and then do that so you can get to see Georgia. Right, well in the meantime, what we'll do is we'll look at reptiles. So we can obviously do physical restraint for reptile radiography. Clearly we don't want to be in with the reptile, obviously for health and safety reasons when we're doing it, but it is possible for some docile ones to be plonked on a plate and walk off and do it. We can obviously use imaginative things like tin cans for things like colonia, just to chock them up so they can't actually wiggle about. Vagal reflexes, you've got grumpy things that you maybe don't want to anaesthetize, may make a big difference and just calm them down sufficiently for a brief period so that you can actually position them. But actually, chemical restraint may be required, particularly if you're going to do something else more noxious to them. Positioning-wise, we're looking at traditionally 2 views, obviously, again. So we're looking at a dorsiventral view and a lateral view. But actually, in colonia and squamates, we're wanting to consider lateral beam radiography. So we're wanting to consider firing the radiographic beam horizontally, so that effectively we're putting the plate vertically behind them. Why do we want to do this? Well, there's no diaphragm in there, apart from the fact it's very difficult to balance a tortoise on its side. You want a normal positioning of viscera. So the lungs are up here in the dorsal carapace, the viscera is down here. You turn the tortoise on its side, the viscera will simply obliterate the lung field and make it almost impossible to interpret what's going on. This also happens in squamates. In snakes, you can get away with vertical beam radiography because they're a bit like fish. All their internal body organs are held with fibrous attachments. So you can put a snake on its side and you can take an image and it will still be interpretable. But for the colonia and squamates, you need to do horizontal beam. And for colonia, we've got a third view that we can use, which is a cranial caudal view. So basically, we're aiming the crosshairs of the beam on the nuchal area, and we're putting the plate behind the colonian, and therefore we can compare right and left lung fields. So if we've got a lung lesion, we not only know where it is in the lung from cranial to caudal, we can also work out whether it's in the right or the left lung field. Clearly the dorsiventral view in these cases is going to give us very little information about what's going on in the lungs, but it will give us some skeletal information. It may be sufficient to tell us about eggs and things of that nature. So these are the sorts of typical 3 views that we're going to get. So dorsiventral, head ends this way. We're going to see things like eggs. We're not going to see an awful lot else, maybe a bit of gas in the stomach, probably not a heck of a lot else, some limbs, and that's about it. Craniocaudal view though, we can compare right and left lung fields. Lateral view, we can see the whole of the lung fields. We may be able to see what's going on with the viscera as well. We may get a bit of an idea of what's going on with the viscera. Colonia are always a challenge because of the shell. But similarly for lizards, horizontal beam radiography, neatly firing out the window, of course, at any passers-by. I hasten to add that was an off area that was out in the back of the window. But nonetheless, firing horizontal beams so that we can get an idea of what's going on with the viscera is preferable, again, because it makes life difficult to interpret things. If we've got a nice horizontal beam, I can see all the lung field and I can see the... Brilliant, thank you very much. Okay, so what we'll do is we'll break a little bit early then so that you get the majority of your lunch break and be back for Georgia at 1:30. The dorsoventral view does not give us a great deal of detail in the lungs because obviously we're looking at the lungs superimposed on the viscera underneath, which is going to be the heart cranially up here. The heart's usually in this area, in the pectoral. The liver lobes, particularly in this area, and then stomach, left side, and intestines caudally, and also in a lot of lizards, fat pads in the caudal area as well. We can do barium and Conway studies, digestive tract studies. This is a corn snake. To orientate yourself with snake images, the ribs always point backwards, so head end has to be this end. Dorsoventral and lateral views. Vertebra, ribs, dorsoventral view often doesn't give you huge amounts of detail because the spinal column I should say, is there in the way, but it does give you a little bit of detail on this particular one. The reason we've done this, we had a lump on this particular corn snake, which on initial fine needle aspirate suggested that it was inflammatory in nature rather than neoplastic, but we were wanting, before we tried to take it out, to work out how far it went. So we did a little contrast study and stomach tubed it with a little bit of Conray, and you can see it comes down to this point here. It's clearly being pinched at this point here, and also in the lateral view you can see it's going over the top of the granuloma in this area, and there's a little bit of a tail off as it goes into the rest of the digestive system there. So this thing is definitely not just subcutaneous, it's actually going inside the snake. And similarly in this one here, in this reticulated python, we filled the stomach, and here we are at the outflow of the stomach. We've suddenly hit a bit of a brick wall where something is blocking it. You could palpate this in this particular snake. It doesn't look as if it's a foreign body. I wondered if it was a tumour. It actually turns out it's a granuloma. So this is the caudal end of the stomach, the proximal end of the intestines, and these typically are associated with abscesses that form from either spicules of bone or teeth from rodents that punch their way through the stomach wall. It's often, although not always, associated with feeding slightly too large a rodent prey to a snake, and then, as I say, they get a little bit of a perforation of the caudal stomach wall, and a granuloma can form, and this one had obviously then effectively occluded the outflow. Normal findings, gravidity, very radiodense in the case of colonia. As far as eggs are concerned, much less radiodense, much more leathery in nature in squamates, so snake and lizard eggs, but you can see the sheer number in this chameleon, lateral view, dorsoventral view in this case. You can see how far up they come. They've got 2 oviducts in these guys, livers on the floor at the bottom here, so you get an impression of these ovoid structures. It is sometimes difficult on small guys to see what's going on. Some normal structures. Do you know what these are in this particular little lizard? Calcium sacs, very good, yeah. So this is a day gecko, this is one of Standing's day gecko, and they actually have lymphatic calcium ducts in these areas for storing calcium. So that is a perfectly normal finding. You radiograph it the first time and go, what on earth is that? This is a perfectly normal feature for this particular species. This particular species here also has some spiky bits at the back of the mouth and the underside of the cervical area, this particular snake. Does anybody know what that might be for? Yeah, I get what you're thinking of. Yes, could be disarticulation. We've got some spikes here. We've got some spikes here. It's not that. This is an egg-eating snake. They have spikes at the back of the mouth. So they take the egg in, and then they contract, and the spikes puncture the egg to collapse it, and then they swallow it. So they don't swallow the egg all the way down whole. They take it into the back of the oropharynx, and then these projections that come off. So if you're looking at it and thinking, oh, well, there's some, spondylosis or some sort of aberrant bony structure there, that's not the case. That's normal for that particular species. There's some fairly abnormal findings in this particular individual, and this is quite significant. So these poorly defined radiographs are poorly defined because there is very little, if any, bone density in this adult female iguana. You can maybe get a bit of an impression of ovoid structures inside the coelomic cavity here. Actually, the liver's all the way up here now at the moment, so there's something filling this area. On the lateral view, again, sort of scalloped edges. But if you look at the bone quality, and often with metabolic bone disease, it's recommended to look at the bone density in a distal limb and compare it with the soft tissue surrounding it. And can you clearly identify the bone in that area versus the soft tissue? Well, in this particular one, it's difficult to differentiate the bone in the antebrachium, let alone in the distal limb. And actually, there really is very poor definition. And this particular female also has a spontaneous femoral fracture over here, and is basically just calcium depleted. So it came in comatose with a hypocalcemic collapse because of inappropriate diet, lack of UV light provision, but she still went and produced eggs. This is post-ovulatory stage. She was in with a male, so actually she developed post-ovulatory stasis and then crashed because effectively she'd used all the calcium that she possibly had. The most mineralized thing in her body is what's in her digestive tract. There's very little else left. And we can see some really serious pneumonic lesions. We're talking about colonia. Again, this view doesn't tell us anything about what's going on in the lungs. The craniocaudal view shows us, well, the lung fields are nearly gone, particularly on the left side. And actually, we can see on the lateral view that the fluffy densities extend the whole length of the lung fields. Now, it doesn't give you the diagnosis as to whether that's pneumonia or whether that is potentially associated with something like congestive heart failure, but it certainly tells you that the entire lung field's being affected, and this animal, even if it's not showing very obvious clinical signs, is quite close to crashing. Similarly, occasionally you might just see a little bit of a difference on a dorsoventral view where there is a very unilateral lesion. So you can get a bit of an idea here, left and right, that actually the right side is perhaps more radiodense than the left, but it's not going to give us that information until we do a craniocaudal view. And then all of a sudden we can see, yes, the right lung field has more radiodense, fluffy densities in the ventral dependent parts than the left lung field. And we can see when we look at it on the lateral, it is much more caudal in nature. The head ends that end. So it's caudal in nature and dependent. So we've got a right caudal dependent lung field. Why is that important? Well, if I want to get to it, to sample it, the best way of doing it is to drill down through the shell to sample it. And so now I know where it is. I know where to position my drill site to actually get to the organism, to sample it, so that I get it on the right antibiosis. Similarly, in snakes, we can see profound pneumonia. So this one here, the heart is in about here. This is supposed to be all the lung field. We've got that bit there, that little tiny bit there. And this snake is still apparently moving about, well, not moving about much, but not, gasping or anything. They often just become anorexic, certainly. They often become just a little less keen to move around. They often position themselves with the head just up because obviously they're trying to keep the fluid down the bottom end of the lung, so they've still got some lung to breathe with. Often, probably not in an advanced case like that, but often if you just gently tip the head downwards, fluid will passively run out of the lungs and into the mouth, and you'll see it coming out. There's no cough reflex in these guys because there's no diaphragm, so there's nothing there that they will cough it up. And a similar case in this particular one here. This one, you can actually see that there is some distortion there, and the lung field starts. This is the heart. There's the lung field starting. There's the heart in this one. Trachea coming down here, lung field. This one actually has cardiomegaly. And this is a corn snake with a cardiomyopathy. Now this one you could see from the outside, you could see the distension. The radiograph gives us a bit of an idea. Yes, it probably is the heart, but it's not going to tell us obviously whether or not that is due to a pericardial abscess, whether it's a tumour, whether it's hypertrophic, whether it's dilated, what's going on. We're going to have to go to ultrasound, which we'll come to in a second. Green iguana, dorsoventral, lateral horizontal beam. Spot the problem. What's wrong? Yes, very good. Rectangular shape. That is a stabilo rubber, which it ate off its owner's floor. Where do you think that is in relation to its digestive tract? So, head is obviously here, knees, head, pelvis. Stomach, yeah, absolutely. That's where its stomach is. So it is quite far caudal. And they actually have, despite being a herbivore, they have relatively short digestive tract. They do have a kind of a multi-leaved increased surface area to their colon, but it's actually quite a short digestive tract. Here's the liver. You can see that sort of triangle on the bottom there. Obviously lung field, air sac, digestive tract. Problem with this horizontal beam is you often get overlay of limbs, particularly hind limbs, which doesn't make life terribly easy to interpret. Lung fields. Heart is up here, right up the top. Iguanids and agamas is right up the pectoral girdle. Very difficult to image radiographically. But yes, that is in its stomach, all the way down there. Kidneys are actually in the pelvis. So again, kidneys incredibly difficult in squamates, in lizards to image. Another green iguana. What do you think is going on? Same two views. Head end, this end, tail end, that end. Yeah, okay, you're on the right lines. Yeah, okay, yeah, that's part of the story. What are we seeing here? Ascites? Yeah, we're seeing fluid. So this is the other great advantage of doing horizontal beam radiography. We get to see fluid where it's supposed to be. If we put that on its side, it would just wash over the whole thing. There's no diaphragm to keep it in the so-called abdominal cavity. You can see that's the liver there. It's now off the floor. The liver's floating. Okay. This is the stomach. It's now, it was down there, should be down there. It's now floating up with the gravel sign. This view, we're looking at it going, well, that could be lung pneumonia, it could be all sorts of things. This view, it's clearly not lung. It's in here. We've lost all contrast in there. And yes, this was an impaction with perforated bowel that had resulted in a coelomitis. It actually survived. Reptiles can cope with phenomenal amounts of problems. This particular bearded dragon, slightly more difficult to see, but lateral view here. This view here shows you the part of the problems with imaging animals that have got very knobbly skin, have got osteoderms. We can see the little pinpoint spots all over the body, which are little areas of increased mineralization in the skin. The lateral view, we're not getting it quite so much, but we can see in this area here, we've actually got a dorsal lung pneumonia in this particular case. This was actually a case of systemic mycobacteriosis. What is also not entirely clear on this particular one, there was a little bit of joint swelling in multiple different joints on this one, but actually this is mycobacterial disease. It could be any other bacterial disease of that distribution, to be frank, but the owner had been feeding it dead guppies from their tropical tank, because that's obviously what an inland bearded dragon lives off. But anyway, yes, had managed to give it Mycobacterium marinum, and then had kept the reptile at suboptimal temperatures, and it developed systemic mycobacteriosis on the back of it. Took 6 weeks to do it, but unfortunately not curable. Right, I think what we'll do is we'll break there. We'll have an early lunch. Were there any questions on that little lot? And then I say those that need to see Georgia, if they want to pop back for about 1:30, Georgia will be here, and then we'll aim to sort of kick off again about sort of 1:45, 2, 10 to 2, something like that, after you've all had your chat with Georgia. Is that okay?